are still coming into the room, so keep on coming in, and I'm going to introduce our speakers. We're just deciding how they want to do this because it's two people, which I know you guys love having two speakers. I know I do. So let me tell you who they are and what we're going to do this morning. And I know you're going to, first of all, look at the schedule. You see that's one of those times that I've done here on the schedule where you literally have no break for 4 hours. So here's the deal. At 10:50, when this one's over, we're going to get up, go out, hit the restroom, and then come back in because you have to get scanned back in anyway. So don't worry about that time thing. We'll make sure everybody's taken care of. All right. So Dr. Lifferth, you heard talk yesterday. He graduated from Indiana University School of Optometry in 2003 and completed a postgraduate residency in ocular disease at the Huntington, West Virginia Veterans Affairs Medical Center in 2003-2004. Since that time, he has practiced in an ophthalmology co-management center for several years at Bennett and Bloom Eye Centers, a hospital-based setting at the Villages, Florida Veterans Affairs Outpatient Clinic, and is now back home again in Indiana as a consultative optometrist with an emphasis in glaucoma management at Center for Sight and Dry Eye Institute in Carmel, Indiana. Dr. Lifferth is fellow of the American Academy of Optometry, a glaucoma diplomate of the American Academy of Optometry, and a member of the Optometric Glaucoma Society. Austin, are you the chair now of the Academy Glaucoma? Tell me if I'm right. Okay, all right.
Yes, thank you.
And then Dr. Fechtner is here he is actually professor and chair of Department of Ophthalmology at SUNY Upstate Medical Center in Syracuse, New York. Dr. Fechtner is an active glaucoma clinician, surgeon, and educator with a particular interest in glaucoma pharmacology, surgical techniques, and diagnostic technologies. He's the associate editor of the Textbook of Ocular Pharmacology and has published over 100 articles, book chapters, and monographs. He's particularly proud to have served for 5 years as executive vice president of the World Glaucoma Association. I love this. You ready? In his spare time, Dr. Fechtner indulges a wicked coffee habit, plays chamber music, and tries to find 25 hours in a day. So that's what you have to ask him about. But seriously, Dr. Fechtner and I had a chance to work together. Wow, there was snow on the ground. When was that? Was that this year?
That would be all year long.
Oh, okay. In Syracuse, that's all
July.
year long. We Florida people don't know what that is. But it was such a good time. I got to tour his facility there and be able to take some time to learn from him how he utilizes technology in his clinic. And when that was completed, I begged him to come in and talk to you because I knew that when the two of these guys got together, we'd have a great learning experience. So I have no idea what we have in store for you, but they obviously do. So let's welcome them.
Thank you, Dr. Fechtner.
Thanks, April. Appreciate that. And we are glad to be here and appreciate the nice introduction. What a great place to talk about glaucoma. We know it's the happiest place on earth and the magical place on earth. And we really feel like we add to that when we bring glaucoma to the stage. So
That's it.
goes along well with it.
Are we ready for prime time? I'm not sure.
So we're glad to be here today. And Rob and I were just talking. We'll see how long we actually sit down. We'll start pacing eventually, but we'll go for a few minutes here. Just a few disclosures. It's really an honor, a treat, a unique experience to be able to have a world-renowned glaucoma specialist with us on stage. So I'm excited to have him here. It'd be like in a clinic if you had a glaucoma specialist with you at all times. So that's something like that. So we hope we'll have some good discussion. We'll present some cases, some treatment options, and hopefully you can ask a lot of questions to Dr. Fechtner for those things that come up. I do have one question for you to start off.
Sure.
The neat thing about this is we've kind of gone through our slides casually, but haven't really gone through them together. So this is unhinged, unpracticed. So
I love that because you really don't know what we're going to see on the screen or what we're going to say, and we don't either. So we set up today where Austin has my content for the morning and may have put some of it in, and I have his content for the afternoon and may have put some of it in. So I hope some of the back and forth discussion we have will actually reflect your real life experience in trying to take care of glaucoma patients and work with colleagues.
I was worried when we said that we don't know what we're going to say if people are going to leave, but it looks like they're still here, Rob. So that's a good sign for us for that. So I have a question for Rob. You know, sometimes how someone will Google your name on the internet, but have you ever Googled your name on PubMed?
Every once in a while I have to check my CV.
Anyway, 75 results. So peer-reviewed articles, I just Googled it last night, looking at some of the articles you've done there, and just want to show you, April did a great introduction for Rob, but this is a unique setting to have someone like this who's so well published and a scholar and a clinician for us as well. Wanted to talk about a couple things as Rob and I were talking about what can we share with you that we've found helpful or that can help us as a profession and as providers. We talked about, well, there's different stages of glaucoma. And if we could find ways we could better diagnose and define those stages as the first part. And then the second part, which we'll talk about in the afternoon session, how can we treat and intervene in those different stages? And by way of introduction, I put up this slide, this spectrum, where it shows on the left side the glaucoma suspect area, normal patients, and it gradually progresses to advanced glaucoma. You know that patients, as I mentioned yesterday, they don't start out with advanced glaucoma. There's something that happens along the way over months or years where they advance to end-stage glaucoma if left untreated.
I have a question here. How many of you consider yourself a glaucoma suspect? I consider every single one of you a glaucoma suspect.
I thought the same thing. You're all suspects.
Yeah.
So good point. So when any patient comes to your office to think about that they're a glaucoma suspect, there's some risk factor that could develop that if we could be aware of, detect that.
Right. So you got to be suspicious.
Yeah.
Maybe
like
that's
that.
because I'm from New Jersey.
No, I think that's a good point there. So with that said, as we look at glaucoma, if everyone's a suspect, I think a lot of it, regardless of the stage, depends on a systematic evaluation of the optic nerve. So we want to make sure that every time we look at the patient, we look at the optic nerve systematically, more than a CD ratio, but some qualitative features of the optic nerve. Along that, though, and I think if you were to do a take-home slide, this would be one that I would think would be most important. That an earlier glaucoma structural test may give us more helpful information, maybe more reliable information in early glaucoma. As the spectrum continues, structure and function has increased concordance. The visual field starts to match the OCT. That's when it's fun, when you have that certainty because they're matching like that. And then on the other side, function for advanced glaucoma, usually functional tests may be more helpful than structural tests. Any thoughts about that, Rob?
I agree with that. Early on, you have to look at the nerve. Eventually, you bottom out on the testing.
Yep.
And it becomes very hard to find progression. We don't want to let patients get that far over.
Right. Right. And so that's why maybe visual field or 10S2 testing might be more helpful in the advanced stages and even earlier stages too, depending on the visual field defect. So fortunately, with this setting like this, we have less prevalence of advanced glaucoma, and with the base being glaucoma suspect, which, as Rob pointed out, is all of us. At some point, all of your patients. And our goal is to keep that base low. It'd be great if someday, Rob, that we could make that advanced glaucoma section just a small sliver of the percentage like that.
Oh, that'd be wonderful. I'd be happy to stay out of the operating room.
And just so you know, that's Rob's world, advanced glaucoma. But I think a lot of us, I'm not smart enough to end glaucoma, but I think we're motivated enough to get to the point where it doesn't get to the point of advanced glaucoma. And for ODs, I think that's our area. We can really detect glaucoma earlier, detect and treat it better, so we get to a point where it doesn't get to that point of advanced glaucoma.
I'd love to highlight that. The best way to not get to advanced glaucoma is to find it and treat it early. And those patients are in your practice, it's not mine.
Yep, I think that's a great point. We can really, and maybe naive, we can really end blindness from glaucoma if we can detect it earlier. So we have 4 cases, 4 stages, 4 main stages here. And we could go a lot different routes. This is like choose your own adventure, choose your own CE course. Is there one topic you want to jump to first that seems exciting to you or interesting to you?
This looks a lot like the Disney app.
Thank you, Disney. Is there one topic sounds good? Or Rob, anything that you, from the audience?
Okay.
What's it? Early detection? So how about we go to glaucoma suspect then for that one?
Okay.
Does that sound all right? I sat for about 5 minutes. That's pretty good. So we'll go to glaucoma suspect here. Let me pull this up. Find my mouse. Oh. Wow, we just finished the lecture.
Well, okay, we're done. It's break.
Any questions? I need to reset that. I'm sorry about that.
What key is that? I don't want to push that one.
Yeah, don't push that one. Okay, let's try this again here. We'll go back to this one here. All right. Yeah, so let's go to early detection. I think that's a key area to focus on. If we're trying to prevent vision loss from glaucoma, then we need to be able to do that. I guess I'm just, oh, there's a slide right there. I see it. Okay. So I think this is an important part for glaucoma, the glaucoma suspect area. To me, this is that clinical gray area. It's a tough area where we all know what advanced glaucoma looks like, but to me, it's challenging to find out, does this patient have glaucoma, that glaucoma suspect, early detection? Maybe you have some pearls, Rob, but it's a hard area to figure out.
I'll mention a little later events and trends. And for glaucoma suspect, if there's an event, if there's a field defect or a notch in the nerve, that's not a glaucoma suspect anymore. So this is a very mushy group. It's the one where